although these lectures aren't divided particularly by topic, this second lecture is slightly harder than the first lecture. But don't let that put you off. I will try and talk you through these slides, and I hope by the end of it you'll enjoy the cases and have a slightly better understanding of some of the rheumatology conditions that come up in membership. So, let's start with question 1. Adrian, a 34-year-old man, presents to his GP with a painless penile ulcer. So I'd start with a question like this, but he's treated empirically for syphilis, and over the following weeks the ulcer resolves. 1 month later, he develops an acutely painful left eye. You can see it in the photo here. He finds bright light very uncomfortable. What is the cause of his visual symptoms? You've got 5 choices. A. Acute closed-angle glaucoma. B. Conjunctivitis. C. Iritis. D. Posterior uveitis. Or E. Scleritis. So the answer here is iritis, and the clue is if you looked at that photo carefully of his eye, he's got what's called a hypopion, so pus collecting in the anterior chamber. So eye symptoms for the MRCP. Remember the eye, you can divide it up into different sections. The uveal tract, and by this we talk about the choroid, the ciliary body, and the iris most anteriorly. So for example, anterior uveitis is inflammation of the iris, so iritis. Those are interchangeable terms, sort of. You can also have intermediate uveitis or posterior uveitis. Scleritis and episcleritis are common eye complaints of the MRCP. And they're important to distinguish. Episcleritis, an often irritating condition, which is itchy, causes the eye to be a bit red, but often the patients won't seek medical attention, whereas scleritis is intensely painful, and the patients will usually present fairly quickly to an ophthalmologist. And how do you distinguish episcleritis and scleritis from, for example, conjunctivitis? And the clue here is that episcleritis only affects the episclera, so it does not extend to the lid margins where the conjunctiva does. Conjunctivitis, on the other hand, if you were to pull down the lid, would affect the lid margins. If you look at this patient, the eye here, you can see that this is episcleritis, where there is the redness around the sclera, and it's the episclera, but the lid looks normal. Part B of this question. Not long after his eye symptoms has improved, Adrian presents at hospital with neck stiffness, headache, and a widespread pustular rash. Blood and lumbar puncture results are shown below. The chest radiograph is normal, and a CT brain shows no focal abnormalities. So what do the blood results show? Hemoglobin 13, the white count is elevated at 16.3, neutrophils 11, platelet count normal, raised ESR, normal glucose. And you've got some CSF results. An elevated opening pressure, that's good they've done an opening pressure. I'm sure you all know you must always do opening pressures whenever you do a lumbar puncture. All too often you see on a medical take a lumbar puncture has been done and no opening pressure recorded, which is such a shame because it is valuable information. And here it seems slightly elevated. Slightly increased red cell count, but the white cell count's definitely abnormal. And when you look at the white cell differential, that's what we call a pleocytosis, a mixture of the white cells. Protein, that's within the normal limits, and the glucose, compared to the blood, the serum glucose is okay. So which diagnosis best explains his symptoms? Behçet's, reactive arthritis, formerly Reiter's syndrome. We should be calling it always reactive arthritis, and I think it's worth mentioning that Reiter's syndrome is no longer a term we use. Lupus, SLE, syphilis, or Wegener's granulomatosis. So Behçet's is the answer that fits here. And let's think about why this is, because I'm sure some of you are crying out to say, couldn't this still all be syphilis? So Behçet's, for the MRCP, should have really added in one additional piece of information. They should have described to you pathogy. And this is pathonomic for Behçet's syndrome. This is the phenomenon where a needle is stuck into the patient to take a blood sample, and after the needle has been removed, over the next 24-48 hours, a pustule develops at the site of venipuncture. That's called pathogy. For MRCP, that is pathonomic of Behçet's. Classically, Behçet's is a combination of uveitis, oral and genital ulceration, venous thromboses, and in this situation, this patient sounds like it may have been a venous sinus thrombus, which would fit with his slightly raised CSF pressure and a pleocytosis. Arthralgias, often lower limb arthralgias, and neurological involvement. And the neurological involvement is characteristically a movement disorder. Why wasn't this any of the others? Well, it wasn't a reactive arthritis because although that would have explained the urethritis, that was an ulcer, it would have explained perhaps some of the other, it wouldn't have explained the CNS involvement, that abnormal lumbar puncture. SLE doesn't really cause uveitis or iritis. Syphilis, well, that certainly would fit, and that has to be your alternative differential. But the thing that goes against that is he was treated for syphilis. And it would be very unusual to have syphilis, get treated for it, and then still to develop disease. And most of these features were diseases that would be part of tertiary syphilis. Vagus granulomatosis. The eye involvement, vagus is an anchor-associated vasculitis. The eye involvement in vagus is more commonly scleritis than uveitis. Question 2. A 44-year-old male presents with breathlessness and a new onset of weakness of his right foot. He has a past medical history of adult-onset asthma, diagnosed 2 years ago, for which he takes salbutamol, salmeterol, fluticasone and montelukast. Sounds like asthma that's hard to control, that. On examination, he has weakness of dorsiflexion and eversion, but preserved inversion. So that sounds like he has an L5, maybe a common perineal lesion. Preservation of inversion, so S1 isn't affected. Okay. The right ankle jerk is absent, that fits, it's a lower motor neuron. And sensation diminished over the lateral aspect of the right leg below the knee. This is sounding like a common perineal nerve palsy. Blood tests. Looking at the blood test, he's anemic, slightly raised white cell count. The eosinophils raised. That's unusual. Eosinophilia, parasitic infections. Creatinine normal. ESR elevated, and you've got a chest x-ray there, which shows bilateral, really quite dense infiltrates in the middle and lower zones. That's a slightly worrying looking chest x-ray. And this should be starting to click alarm bells now for what the diagnosis might be. We're thinking vasculitis maybe? Which two of the following investigations would not be appropriate? Okay, so is this going to catch us out anywhere? Anchor testing, blood cultures, coagulation studies, CT chest, D-dimer, lung function tests, MRI brain, nerve conduction studies, sural nerve biopsy, urinalysis. Have a think about these. Put your money on which two you wouldn't do. So when I was thinking about these, I mean, this is multi-system involvement. High ESR, this sounds like vasculitis, and the eosinophilia is pointing me towards Churg-Strauss. I definitely want to check the anchor here. As always with vasculitis, the main differential is often an occult infection, so I'd like to see blood cultures. I wonder about that chest x-ray being pulmonary hemorrhage maybe, so coagulation studies definitely, CT chest definitely. D-dimer, MR brain, I'm not so sure about that actually, because he's not had any central nervous system involvement. His neurological functions are lower motor neuron, and rather actually nerve conduction studies, sural nerve biopsy, those look like useful things. And so I think D-dimer and MR brain are the ones that wouldn't be appropriate here. The others and the others would be appropriate. 2B, pulmonary function tests. So they've got an FEV1 that's 38% predicted, that's low. FVC 52% predicted. The peak expiratory flow rate in the first second, that's 51%. And the DLCO, so the transfer factor, that's elevated at 118%. That's a bit unusual. What's the likely explanation for this? They offer you asthma, bronchiolitis obliterans, pulmonary hemorrhage, respiratory muscle weakness, usual interstitial pneumonia. So there's not many causes of a raised transfer factor for MRCP. And pulmonary hemorrhage has to be top of the list. And that fits with what we think is going on with this patient. That was what that chest x-ray looked like it might be. There is another cause for MRCP that you should remember in the back of your mind, and that's pneumonectomy. And it's pneumonectomy only if the transfer factor has been adjusted for lung volume. Because if it's adjusted for lung volume, what you tend to find is hyperexpansion of the residual lung. So you can see a raised transfer factor, so hyperemia of the residual lung. So you can get a raised transfer factor after pneumonectomy. So the question here is, what is the unifying diagnosis? A, allergic bronchopulmonary aspergillosis. B, Churg-Strauss syndrome. C, Goodpasture's disease. D, microscopic polyangiitis. E, tropical pulmonary eosinophilia. I'll let you think about those for a moment. So, unifying diagnosis in this patient. I hope at this point we should be tying this together and saying this is B, Churg-Strauss syndrome. Allergic bronchopulmonary aspergillosis? Well, that certainly doesn't explain the pulmonary hemorrhage. ABPA does cause chronic asthma that is difficult to treat. It tends to cause sometimes perihilar or upper zone infiltrates in people with unresponsive to treatment asthma, and it's an allergic phenomenon in the lungs. It's not actually an infective process that's going on, it's an allergy to aspergillus. So if you culture the lungs, you don't tend to find aspergillus, but if you do aspergillus precipitans or an aspergillus-specific IgE, they will be very high. Goodpasture's disease, so that's anti-glomerulum basement membrane disease, causes pulmonary renal disease. And I wouldn't certainly start accounting a foot drop start attributing a foot drop to Goodpasture's. Microscopic polyangiitis? Well, that's another one of these ANCA-associated vasculitides, but it doesn't quite explain the eosinophilia. We'll ignore it. That was a red herring thrown at you. So Churg-Strauss is this classic pattern, a history of asthma in a patient, often with quite a marked eosinophilia, often much more marked than what I've shown you, with this multi-system involvement. And it is one of what we call the ANCA-associated vasculitides. So I think you ought to know a little bit more about ANCA and about the ANCA-associated vasculitides. If you're on the ward round and you have a patient who has a pulmonary renal syndrome, and it should be people with multi-system disease should be thinking about vasculitis. When you see a patient like this on the ward round and the consultant says, what do you think this might be? I think it's very reasonable to say, I think this could be an ANCA-associated vasculitis, because that encompasses the majority of the serious systemic necrotizing vasculitides. The ones that are classically ANCA-associated are these three here: Churg-Strauss, microscopic polyangiitis, and Wegener's granulomatosis. And these describe clinical syndromes that are all different, but the initial investigations and treatment are along a very similar line. So I would use the phrase ANCA-associated vasculitis as a sort of lumping term for vasculitis. And when we talk about ANCA, it's important you understand what this test means. There's two ways we can test ANCA. We can do an immunofluorescence, which can describe a pattern of ANCA staining on neutrophils. On the top here being a perinuclear or P ANCA staining pattern, and on the bottom a cytoplasmic or C ANCA staining pattern. P ANCA staining is characteristic of Churg-Strauss syndrome, while C ANCA staining is characteristic of Wegener's granulomatosis, and microscopic polyangiitis can fit either. But importantly, we now have gone on to know that this immunofluorescence pattern corresponds to particular antibodies against certain antigens. In P ANCA, it's an antibody to myeloperoxidase, or MPO. In C ANCA, it's an antibody to proteinase 3, or PR3. And importantly, you can get false positive immunofluorescences for a lot of other reasons, like sepsis, for example. While it's very unusual to get a false positive antibody to MPO or PR3. So whenever you request an ANCA result, always check both the immunofluorescence for P or C ANCA and the antibody result, the ELISA, for MPO or PR3. In the absence of a positive ELISA, the ANCA may be a red herring. The different diseases, I've mentioned Churg-Strauss. Wegener's is the other one you need to be aware of, and this is the one that classically involves the ENT. They present with midline structure involvement where they get granulomatous disease. They may give you a history of nasal crusting, of hearing loss. associated with pulmonary renal involvement, rashes, vasculitic rashes, neurological disease. Question 3. A 40-year-old male presents with a 7-day history of fever, malaise, arthralgia, sore throat, and a rash. He's got everything wrong with him. No past medical history of note. Other than regular paracetamol for the last few days, he takes no other medication. And on examination, there are multiple large cervical lymph nodes. On cardiac auscultation, there's a pericardial friction rub. And the abdominal findings include a palpable spleen. There's no visible rashes when you examine him. You've got some blood test results available. He's got an anemia, a high white blood cell count, quite high platelet count 744. So INR is normal. He's got a CRP of 433 and an ESR of 111. His renal profile looks normal. He's got abnormal liver enzymes. He's had a negative HIV test. And on the immunology front, there's ANCA ANA rheumatoid factor negative, and he's got some sterile blood cultures. He's admitted to hospital for further investigation, and during the admission he has a temperature chart kept, which is shown here. So which of the following diagnoses fit best? A. Adult onset Still's disease. B. Giant cell arteritis. C. Lyme disease. D. Systemic lupus erythematosus, SLE. Or E. A subphrenic abscess. I'll let you think about these for a minute. So just putting together what he's presented with. Fever, arthralgia, sore throat, a rash, although there's nothing to see when we examined him. Clinically, though, the hard findings are pericarditis and splenomegaly. Add in the blood pictures. Well, the things to notice from the blood, he's got very high inflammatory markers. His liver enzymes are abnormality, and it's a hepatic pattern, a hepatitic pattern, rather than, for example, an obstructive pattern. And tests for infections are negative, because certainly this would fit with endocarditis or a subphrenic abscess, for example. That would have been a great explanation, but blood culture's sterile, HIV negative, and his autoantibodies are negative, which sort of throws you away from a rheumatological diagnosis. Or does it? And actually, looking at his temperature chart, there's something quite rheumatological about his temperature chart, and that's that the fevers go sky high, but return to baseline every time. That's unusual for an infection. Infections, they normally go up and stay up, go up and down a bit, but rarely return to baseline. So this is a classic presentation of adult onset Still's disease. And it ties it all together with this rash in Still's disease that comes and goes. It's described as an evanescent rash. That means it comes and goes. Typically coming in the evenings, it's described as a salmon pink rash, and it tends to accompany the fever. And the fevers occur on a daily basis, and the fever always completely resolves. The other classic thing about Still's is that they tend to have very high inflammatory markers. Ferritin, one of the other acute phase proteins that you can measure, often is found in excess of 10,000. And although that's not specific, it's something that's often used. And anecdotally, people always say, if you think it might be Still's, check a ferritin. Question 4. Brian. He's a 69-year-old man who attends a respiratory clinic with progressive breathlessness, wheeze, and fevers. His past medical history is unremarkable aside from recurrent bouts of ear pain. He describes this as his ears becoming intensely painful and red for several days at a time. During the attacks, he cannot lie on the affected side in bed. Both ears are intermittently affected. He has never smoked, and some pulmonary function tests are shown here for you. His FEV1 is really quite markedly reduced, around 38% predicted, while his FVC is relatively preserved at 93% predicted. There's no evidence of reversibility with bronchodilators, and his transfer factor is good at 84%. And you've got a dreaded flow volume loop shown there. Okay. And although you may have been hoping to guess at the diagnosis already, the first question is, what do the flow volume loops demonstrate? A, fixed upper airway obstruction. B, obstructive lung disease. C, restrictive lung disease. D, variable extrathoracic obstruction. Or E, variable intrathoracic obstruction. So, those dreaded flow volume loops. And I apologise to any of you that want to be respiratory physicians and particularly enjoy flow volume loops, but I'm not a fan myself. So let's have a look at this flow volume loop. So, this is definitely a scenario of pattern recognition. What should the flow volume loop look like? Well, the dotted lines are the normal flow volume loop, with inspiration on the lower half of the graph, expiration on the upper half. I'm going to leave the dotted lines in place and just show you some examples of flow volume loops. So this is someone who's got obstructive lung disease, for example asthma or COPD, and what you can see is that the lung volume is diminished, the expiratory phase of the loop is very abnormal. That's the most abnormal part. You might say it looks like a church with a steeple. You might not say that, but that's quite often something described in a textbook. The shape of the expiratory part is the abnormal part. Compared to restrictive lung disease, where actually the abnormal part is the lung volume, but the shapes look remarkably like the normal flow volume loop shapes that you'd expect. Variable extrathoracic obstruction. In this, the extrathoracic obstruction, the expiratory part of the loop looks normal, the inspiratory part of the loop, the curved part of the loop, is diminished. It's the exact opposite of this with an intrathoracic obstruction. The inspiratory part, the curved lower part of the loop, looks normal, but in the intrathoracic obstruction, the expiration is what is affected. It's all about our patient. He didn't fit into any of those patterns. Both inspiration and expiration are markedly abnormal, and it doesn't fit that obstructive church with a steeple pattern that I showed you first off. So what could this be? Well, the only choice left on that list was a fixed upper airway obstruction, and that's what this is. It's an obstruction that doesn't change with inspiration or expiration. So thinking about this gentleman, he's admitted for further investigation. On examination, he has a tender MCP squeeze bilaterally. There's a saddled appearance to his nasal bridge. Blood pressure is normal, urinalysis is normal. Which two of the following investigations will be able to confirm the underlying diagnosis? And you can choose from A. Acetylcholine receptor antibodies, B. ANCHOR, C. Biopsy of pinna, D. Blood culture, E. Bronchoscopic lung biopsy, F. Chest CT, G. HIV test, H. Retinal biopsy, I. Serum ACE, J. Urine toxicology. So the two tests that you want to do here are going to look for the underlying diagnosis, which in this gentleman sounds like relapsing polychondritis. And you want tissue to confirm this. Biopsy whatever you can. In this case, the affected organs are the ears, so biopsy of the pinna, and the lungs, so a lung biopsy. And those are the two tests that are probably going to point you in the right direction for this. And you could argue that some of the others might have been interesting. They're trying to throw acetylcholine receptor antibodies if you had misinterpreted the flow volume loops as being someone who might have a neuromuscular problem. They try and throw in urine toxicology if you think he's got cocaine causing damage to his nasal bridge. But really, the ears are what give this away. Relapsing polychondritis is extremely rare, even in MRCP exams, but nothing else like it causes inflammation of the ears, alternating left or right auricular inflammation. And it's a disease that causes autoimmune destruction of cartilaginous structures. And although the ears are the one that often present, when they often give you the clue to the diagnosis when they first present, the really crucial part of this is that it causes damage to the midline cartilaginous structures, nasal bridge, also the airways, and they get airway collapse. Question 5. Archibald, a 49-year-old man, presents with difficulty walking. His symptoms have been gradually progressing for several weeks now. His past medical history includes seronegative arthritis, which was diagnosed 18 months ago. On examination, there is marked proximal weakness, which is symmetrical. Reflexes are normal, and sensation is preserved. You have some blood results here. His hemoglobin is 9, his MCV 101, white count 7.6, ESR 100, INR 1.0. His renal function looks normal. His albumin is low at 29. Normal CK, elevated alkaline phosphatase. B12, that's low, folate, that's low, and his blood film, a dimorphic blood picture. That would sort of fit, wouldn't it? He's got a low hemoglobin, low B12, low folate, and you wonder if maybe that's because he's got a low ferritin as well, giving the dimorphic blood picture. Which of the following best explains his muscle weakness? A. Amyotrophic lateral sclerosis, B. Hypothyroidism, C. Polymyalgia rheumatica, D. Polymyositis, E. Vitamin D deficiency. So this sounds like vitamin D deficiency. The normal CK makes you think this is unlikely to be myositis, although it doesn't exclude it. Hypothyroidism, well, that could explain the weakness. But the thing that points us towards vitamin D deficiency, the elevated alkaline phosphatase with proximal muscle weakness, combined with, he's got other markers that suggest he's malabsorbing. Low albumin, low B12, low folate. So E is by far the best answer here. So vitamin D deficiency is not an uncommon thing in real life. We see it in certain populations. Vegetarians, people who because of their ethnicity choose to cover their skin, and people that live in areas where they are relatively sunlight deficient, for example, northern European countries. The presentation is typically with proximal muscle weakness, sometimes with visible evidence of bony damage because of poor mineralization. They develop osteomalacia, which radiologically is shown as Lucer's zones. Think about in this patient though, concurrent malabsorption, and celiac disease is a classic MRCP trigger for vitamin D. So if you see someone with a history of celiac disease, muscle weakness, think vitamin D. So this gentleman's admitted for investigation, so it sounds like the vitamin D deficiency isn't the end of the story. His wife is concerned he's also becoming increasingly forgetful. A mental test score, 25 out of 30, but actually in that, 0 out of 3 on short-term recall. Antibodies to tissue transglutaminase are negative. Damn, that was sounding like celiac. Serum IgA is normal. That's useful because celiac disease is associated with IgA deficiency. Tissue transglutaminase is an IgA-based antibody test. So if you're IgA deficient, you can get a false negative tissue transglutaminase. So we always check IgA when we screen for celiac. In view of this gentleman's malabsorptive state, though, an endoscopy is arranged. They've shown a biopsy. That's a disaster, isn't it? I'm hopeless at biopsies. He's got a distal duodenal biopsy result. Both are stained with hematoxylin and H&E. And you've got the pictures there. What is the diagnosis? A. Celiac disease. B. Crohn's disease. C. Intestinal tuberculosis. D. Langerhans cell histiocytosis. Or E. T. Whipple infection. So, I agree. Slides, when they put up in part 2 a picture of histology, if you've seen it before, great. But for the most part, histology can be confusing to the non-histologist. But remember, this is a game of pattern recognition. If this was celiac disease, and I agree it still could be, because you can't exclude it on the basis of blood tests alone. You still need to do a distal duodenal biopsy. But the finding is villus atrophy. That slide I showed you didn't appear to have villus atrophy. The villi look normal even to my eye, and I'm definitely not a histologist. H&E stain, was it going to be TB? Well, TB doesn't show up very well. TB, you want an auramine or ZN stain. Crohn's disease. Well, I suppose that could explain the arthritis, because you can get a enteropathic arthritis, but doesn't explain the memory loss, unless that's tied into... We'll ignore the Langerhans cell histiocytosis, and let's just think, could that biopsy have been the famous foamy macrophages that are described in Whipple's disease, that classic cause of arthritis, malabsorption and neurological decline? And sure enough, that is the correct answer here. This is Whipple's disease, caused by Trophoema whipplei. I can't say that properly. I'm not going to try again. Characteristic periodic acid shift staining within foamy macrophages on histology. If you're lucky, they'll describe the histology as saying foamy macrophages. If you're unlucky, they'll show you a picture and describe a classical clinical history. The treatment, 12 months of antibiotics, typically Cetrin or tetracycline-based regimes. Question 6. A 64-year-old man presents with back pain. Which of the following are not considered red flag features? So two of these are not red flag features. Age over 55, exacerbation with activity, fevers, history of cancer, thoracic location of pain, pain radiating down both legs, previous history of mechanical back pain, raised inflammatory markers, urinary retention or weight loss. So the two here that should jump out at you are exacerbation with activity and previous history of mechanical back pain, because those are the classic features of a person who presents, a middle-aged person who presents with chronic low back pain, and those should not be red flag features in your mind. The others should be. Age over 55 or under 20, fevers, history of malignancy, thoracic location of back pain is very unusual. In a woman, it particularly worries you because that's the classic site for breast malignancy to spread to because of the lymphatic drainage. Pain radiating down both legs. Again, if this was a disc protruding, discs can protrude to the left or to the right, but to protrude both ways, it either means a central canal compression or this is something that's not a disc, this is perhaps a metastatic infiltrate. Inflammatory markers, they should be normal in chronic back pain. And urinary retention, I mention that, I'm sure you all know this, but it's just an important thing. The bowel and bladder symptoms people complain of, well actually they tend not to complain of them because the urinary symptoms, they're unaware they go into retention and you identify they have a palpable bladder on examination. It's not urinary incontinence. And the fecal incontinence, they rarely admit to, so it's something you actually have to specifically ask about. This is an x-ray of this gentleman's lumbar back. You can see down here there's an abnormality. Blood cultures are positive for coagulase negative staphylococci. Which two of the following are not appropriate management steps? I'll let you have a look through this list and give you a moment to consider your options. So the incorrect answers here are C and J. C, IV ciprofloxacin, that's definitely wrong because this is coagulase negative staph. If that's what you're trying to treat, an old quinolone like ciprofloxacin has very poor staph coverage. And aside from anything else, IV cipro has the same bioavailability orally, so you wouldn't give it intravenously anywhere unless they were nil by mouth. And urine for ZN staining, that's wrong on two accounts. Firstly, the Zeal-Nielsen stain is a relatively outdated stain for TB. We're tending to move more towards auramine staining, which is an immunofluorescent-based stain. But also, the days of doing early morning urines as a screening test for TB are gone. That's got a very low pickup rate, and you should really only do that when you're highly suspicious of bladder or renal TB. And when you think about the others, they're all quite important and sensible steps. He's definitely going to need admission. He's going to need a lot of analgesia. That lesion you saw would have been very painful. You need to confirm this is an infection because coagulase negative staphylococci are commonly contaminants, but they're also an important cause to consider in someone with vertebral discitis. So you need to repeat the blood cultures to see if you can prove that those organisms are still there. He's probably going to need more imaging and a biopsy, because the other thing you worry about is whether this could be something other than just an infection. For example, metastatic disease from a prostate malignancy or possibly myeloma, hence the serum immunoglobulins. If, however, you do confirm this to be an infected discitis, then anyone with discitis, you need to look for the source. Endocarditis would be top of my list, and so this gentleman definitely needs a transesophageal echo if you do confirm that this is an infective discitis. Question 7. We're nearing the end. Terence, a 55-year-old man who has hemochromatosis, is referred to rheumatology with bilateral hip pain. Plain radiograph is shown below. What is the radiographic diagnosis? A. Ankylosing spondylitis. B. Gout. C. Osteoarthritis. D. Rheumatoid arthritis. E. Trochanteric bursitis. So have a look at the radiograph carefully. Have a think about what the radiographic features are, and I'll let you choose your diagnosis. So the answer here is osteoarthritis. And although you may have been thrown by his hemochromatosis trying to come up with something that would tie this together, the radiographic features are really quite clear. And these are the characteristic features of osteoarthritis: loss of joint space, osteophyte formation, subchondral sclerosis, and bony cysts. Remember that osteoarthritis is, if you like, it's a disease of cartilage, and as the cartilage becomes worn, you lose the joint space, because the joint space reflects cartilage. And the pattern of osteoarthritis, what's happening at a sort of molecular level, at a cellular level, is that as you lose the cartilage, the bony remodeling that occurs doesn't replace cartilage with cartilage, but tends to replace it with bone. And as a result, you get these osteophyte formation, these osteophytes forming. The subchondral bone tends to appear whiter, that's probably a reflection of pressure increase. And underneath that, you get bony cyst formation. And that's part of an aberrant bone healing pattern. So think about this gentleman some more. Terence presents acutely to the hospital with a hot, swollen right knee. A joint fluid aspirate is shown. What is the diagnosis? A, gout. B, pseudogout. C, osteoarthritis. D, rheumatoid arthritis. E, septic arthritis. I'll let you think about these for a moment. So the answer here is pseudogout. And this photograph here of a polarized micrograph shows this positively birefringent crystal, this small rhomboid-shaped crystal. So this is the association of hemochromatosis, is that they are prone to early osteoarthritis and attacks of pseudogout, or the other name for pseudogout is calcium pyrophosphate deposition disease. What you can see here is a polarized micrograph. And if this was gout, it'd be a very different appearance, because the crystals of gout are negatively birefringent and they're long and needle-shaped, very different in appearance. When you see people with gout or pseudogout for the exam, well, there are associations, but it's often the history that gives you a clue that one of these two conditions is going to be the diagnosis. Because crystal arthritis presents in a very acute fashion. Unlike, say, sepsis in a joint, where the patients will often start to develop symptoms, have systemic malaise and fever, and will go from maybe an aching joint on a Tuesday through to hospital attendance on a Saturday with a very painful joint, crystal arthropathies tend to present with no symptoms in the morning, an ache by lunchtime, and then severe pain by late afternoon, early evening. And that very rapid onset of no symptoms to maximal pain within 24 hours is almost solely seen in people with crystal arthropathies, and gout particularly so. Remember, gout is the disease that we tend to associate with people with a lifestyle that accommodates gout, people that can live well. It was called the king of diseases and the disease of kings, because king of diseases, it is very severe. Disease of kings, you need to eat and drink well to get it. I'm not going to go into the details of gout, but I would recommend you have a look about gout on the UK Gout Society website, www.ukgoutsociety.org. Pseudogout probably is common, but a different population. Gout tends to affect young people in their 30s or 40s or 50s when it first presents. Pseudogout is a condition which tends to affect people with underlying osteoarthritis. More common as you get older, so often people over the age of 65, 70, more common in women. And it's probably a reflection that people who have osteoarthritis, who have cartilage damage, will release some of the bony mineral into the synovial fluid. And calcium pyrophosphate is, of course, a component of the bone mineral matrix. And for some reason in some people, and we don't know why, those crystals cause an inflammatory